Imagine this. You get a lab test result back. Maybe something routine like cholesterol, or maybe something, more significant for a health decision.
Mm.
Or maybe you're reading about a clinical trial, a new breakthrough. We see that final number, that finding, and we tend to just, well, trust it.
What do you do? Yeah.
But have you ever really stopped to think about what goes on behind that result? The immense effort, the precision, what systems make sure it's reliable and safe?
It's a whole hidden world, really. That trust. It's not just assumed, it's earned, built on, well, layers of rigorous practice.
Right.
And that's exactly what we're diving into today. We're looking at the Indian Council of Medical Research's Good Clinical Laboratory Practices, the GCLP guidelines from 2021.
Okay, so this official ICMR document, that's our source material for this deep dive, it is detailed, pretty technical in places.
It can be.
But our mission today is kind of be your guides, right? Pull out the core ideas, the essential steps, maybe some surprising bits too. We want to understand GCLP, what it is, why it's so crucial, for everyday healthcare and for research in India, and how this whole system guarantees quality, integrity, safety.
Yeah, think of it as a shortcut, maybe, to appreciating all that unseen work, the complexity. That makes lab data trustworthy, the data you rely on.
Okay, let's unpack this then. Why do we even need GCLP? I mean, what's the fundamental reason?
Well, it boils down to just how vital, reliable lab data is. Think about patient care. Getting the diagnosis right, the treatment right, it hinges on accurate lab results.
Totally, if the lab's off.
Exactly. The doctor's working with bad info. And for research, if the data isn't trustworthy, well, the findings are basically useless. You can't build medical knowledge, develop new therapies, anything really, without solid data.
And the context here, the document mentions this, is the huge growth we've seen. Healthcare, research, it's all expanding rapidly.
Right. And that growth means more demand. And more demand puts, well, pressure on quality.
Makes sense.
So GCLP's goal is very clear: timely and accurate processing of biological samples. And the knock-on effect is huge. Earlier diagnosis, better patient safety, better outcomes, and, for research, reliable data you can actually base conclusions on.
Now, these guidelines, they're not totally new, are they? The document says 2008 was the first version. This 2021 was a revision. Was there a big change?
There was, yeah, and it's pretty significant. The 2021 guidelines specifically pull clinical research involving human participants right under the GCLP umbrella.
Ah, okay.
The older ones were maybe more focused on routine diagnostics.
Yeah.
This revision basically says, look, if you're doing research with human samples, you need to meet these same high standards. Quality has to be consistent.
And that's where it connects back to you, the listener. Whether you had a blood test last week or you're just interested in how clinical trials actually work, this system, GCLP, it's the foundation. It's what makes sure that information, whether it impacts your health directly or pushes medicine forward, is dependable.
Absolutely. And the scope is pretty wide because, well, human samples get used for a lot of things: diagnosis, patient care, disease control, and, like we said, clinical research. GCLP applies across the board.
So we're not just talking about one specific type of lab test. It covers, what, microbiology, hematology?
Yep, molecular biology, clinical biochemistry, histopathology, loads more. Basically, if it's a clinical lab handling human samples, GCLP is relevant.
Okay.
Right. So now let's zoom in a bit. What actually makes up this system? The guidelines kind of break it down into, let's call them building blocks: the place, the people, the equipment, and the stuff they use, the materials.
Let's start with the place. Infrastructure sounds like it's much more than just, four walls and some benches.
Oh, definitely. The physical design, it directly impacts quality, how efficiently things run, and crucially, safety.
So what are some key things they mention?
Things like clear signage, following safety regulations, having emergency plans, for fires, spills, reliable power, water, controlled ventilation and temperature. That's a big one.
Right.
And critically designated separate areas. This is key to avoid cross-contamination.
Like what kind of separate areas?
Well, reception, where samples come in, a place for sample collection with privacy, importantly. Then the actual work areas: storage, waste handling, cleaning areas, admin space, and, yeah, completely separate spot for staff to eat and drink.
You really don't want someone's lunch next to a patient sample.
Definitely not.
Yeah.
That separation, it seems like common sense, but having it formally required and designed in, it's vital. And access to the main lab areas. Restricted, only authorized people allowed.
Okay, so that's the space. What about the people? The document calls them the most important resource.
It does, and I think that's spot on. You can have the fanciest machines, but without skilled, trained people.
It doesn't mean much.
Exactly. So the guidelines define key rules. You've got a laboratory director, they're like the overall boss,
Right.
responsible for operations, safety, making sure staff are competent, the quality system runs, everything.
Okay.
And then there's a quality manager. Their job is crucial. They independently monitor the quality management system, the QMS, and report straight to the director. It creates a kind of check and balance.
Right. And staffing levels. Got to be enough people for the work.
Yep, appropriate for the workload and how complex the tests are. And they stress optimizing the workflow, the whole process, from sample arrival to report to cut down the chances of errors happening.
Documentation sounds huge, too. Written procedures.
Essential. Procedures need to be documented,
Yeah.
controlled copies available, reviewed regularly, at least once a year, and archived properly. Imagine trying to keep things consistent without clear, up-to-date instructions for everyone.
And training must be a big part of this.
Huge. The goal is skilled staff who understand the why, follow procedures, perform accurately, and, feel confident. A less stressful environment because they know what they're doing.
What kind of training?
There's induction for new staff, getting them oriented, and then ongoing specific GCLP training for everyone involved in handling samples or data. It's not a one-off. It needs to be frequent enough to keep people current.
And how do you make sure the training actually works? That people are competent?
Good question. The guidelines require periodic competence assessment, ideally every year.
What does that look like? Not just a paper test, I assume.
No, it's very practical. Observing staff actually doing the work, testing, sample handling, maintenance, reviewing their results and records, checking their problem-solving skills. For some techs, even things like checking visual color discrimination.
Okay.
Plus, continuing education is key. And all this training records, competence assessments, health records, any incident reports gets kept in their personnel files.
All right, space people. What about the tools, the equipment?
Right, equipment. It's not just have machines. First, selection they have to meet the lab's requirements, capacity, design, etc. Then, before you use major equipment on patient samples, it needs to be formally qualified.
Qualified, like tested.
Exactly. Think of it like proving it's fit for the job. There are different stages. Installation qualification, or IQ, was it installed correctly? Operational qualification, OQ, does it run like the manufacturer says it should? And performance qualification, PQ, does it actually produce accurate results in the lab's hands with real conditions?
It's like a really thorough test drive.
Precisely. Small things might be exempt, but for your main analyzers, centrifuges, things like that, these steps are vital. Maintenance is also critical. Regular inspections, cleaning, detailed logbooks for each instrument, and the SOPs, the procedures for using and maintaining it, they should be right there, easily accessible near the equipment.
And accuracy, keeping the results true.
That comes down to calibration and verification. Absolutely fundamental. Calibration is about linking the instrument's measurements back to recognized standards, like national standards from NPL India, or for radiation, BARC. This ensures traceability.
Meaning a result here should match a result there, in theory.
In theory, yes, if both labs are properly calibrated to the same standard. Verification is more the day-to-day check, using control materials with known values to see if the instrument is hitting the target consistently.
So calibration sets the ultimate benchmark. Verification checks you're staying on target.
You got it. They also mention harmonizing results. If you have multiple machines doing the same test, comparing them regularly, say every 6 months, to ensure they give equivalent results.
Yeah.
And basic stuff like annual electrical safety checks, keeping records of any breakdowns, it's all covered.
And disposal, too, when equipment gets old or broken.
Yep, proper procedures following guidelines. Which leads us nicely to the consumables, reagents, kits, other materials. They matter just as much.
Right. Bad ingredients, bad result, no matter how good the machine or the tech.
Exactly. So they need to be standard quality, fit for purpose. And when a lab gets a new batch, a new lot of a reagent, they have to verify it.
Check it against the old one.
Yeah, check its performance against controls or standards or even retain samples before using it on patients. This ensures results stay consistent over time, even when you switch reagent batches. Any reagents made in-house need stability checks too.
Labeling must be super important.
Yeah, absolutely critical. Reagent labels need full details. Name, batch number, manufacturing date, expiry date, date opened, storage conditions, who opened it. If you prepare working solutions in the lab, even more detail. Date prepared, content, strength, who did it, expiry, no ambiguity.
Storage following the manufacturer's instructions, disposal.
Hazardous or expired stuff. Strict adherence to national international guidelines. And a really key rule, single-use disposables, needles, tubes, whatever, must never be reused. That's a huge safety point. Even water quality gets checked, usually needs to be distilled deionized water. And radioactive materials have their own AERB guidelines.
Okay, foundation laid, right space, trained people, qualified equipment, verified materials. Now, let's trace the sample's journey. The guidelines really hammer home that the pre-examination phase before testing even starts is where most errors happen.
It's such a critical point. Get this wrong, and everything downstream can be compromised. It starts right with patient preparation.
Like fasting before a blood test.
Exactly. Or collecting a sample at a specific time for certain hormone tests. If the patient isn't prepped right, the sample might not reflect their true state.
Then the collection itself. Need clear procedures, trained staff.
Yep, SOPs are essential. Standard safety precautions for everyone involved. Using closed systems, like vacuum tubes for blood, is generally safer and better for sample quality than open needles. Getting it into the right tube with the right additive or anticoagulant, and making sure it's sealed properly to prevent leaks.
And for clinical research samples, extra steps.
Yeah, definitely. Proper counseling for the participant, getting written informed consent is mandatory, and being sensitive to their comfort during the collection process.
And here's that safety point again. All clinical samples, whether for diagnosis or research, must be treated as potentially infectious.
That changes everything. It means every single sample is handled with care, with precautions. Labeling and documentation at this stage, non-negotiable. At least 2 unique identifiers on the sample name and date of birth, or a unique ID number. R codes really help reduce errors here.
What needs to be on the label?
Patient info, the test ordered, date and time of collection, and the requisition form that comes with it needs all that, plus maybe patient location, sample source, and ideally some clinical context like provisional diagnosis. Helps the lab interpret results, and it needs a signature.
What about samples collected outside the lab? Getting them to the lab?
Transportation needs its own SOPs and trained staff. You've got to maintain sample integrity. Think about temperature control, protecting from light if needed, proper packaging, getting it there on time, keeping the transporter safe, and ideally having a tracking system.
But even with all that, sometimes a sample just isn't good enough to test.
Right, that's the sample acceptance or rejection step. Labs have clear criteria. When a sample arrives, they check, right container, enough volume, temperature okay, does it look right, like is a blood sample hemolyzed if that matters?
Yeah.
Any leaks?
And they record all this.
Every acceptance, every rejection, with the reason why. If it's rejected, you need to tell the doctor or patient quickly so they can get a new one. Although the guidelines say be extra careful with precious samples like CSF or a biopsy where recollection is tough or impossible. Try to salvage, if you can, within limits.
And that rejection data isn't just filed away?
No, it's valuable intel. Analyzing why samples get rejected helps labs spot problems. Maybe phlebotomists need retraining on fill volumes, maybe your transport route has issues. Common reasons listed are things like unlabeled tubes, broken containers, leaks, not enough sample, wrong tube type, or it took too long to arrive.
Okay, sample accepted. Now for the actual testing, the examination processes.
Key thing here, labs must use test procedures that are verified or validated. Verification means confirming a standard, published method works correctly in their specific lab environment. Validation is more rigorous, needed if they develop a method in-house or modify a standard one significantly. And you need to record who actually performed the test.
And SOPs, again, the standard operating procedures.
Absolutely critical for this phase. So the recipe book ensures everyone performs the test the exact same way, every single time. Consistency, quality, they need to be clearly written, easily available right where the test is done, and staff must be trained on them.
What goes into a test SOP? Sounds like more than just step 1, step 2.
Oh yeah, much more. It covers the principle behind the test, its sensitivity, the range it can measure, what kind of sample is needed, the reagents and equipment, how to do calculations, the QC steps involved, things that might interfere with the result, the normal reference ranges, the clinical significance. A list of critical alert values, results so abnormal they need immediate action safety hazards, limitations of the test, and the references it's based on. It's a complete guide. You also need to understand the method's performance characteristics, like its precision, accuracy, analytical range.
Okay, testing done. Now getting the results out. Release of test results.
The final report needs all the key info. Patient identity, lab identity, sample details, test name, the method used, the result itself with units, the reference interval or cutoff, and it needs to be signed off, authorized.
What if a mistake is found later? Can reports be changed?
Yes. But there has to be a defined procedure in the SOPs. The reason for the change must be recorded, and the amended report clearly indicates it's been changed. Transparency is key.
And those critical values you mentioned.
Super important. Labs must have a list of these results that could indicate a life-threatening situation. Think like critically low blood glucose, or a pathologist seeing urgent signs in a biopsy, or identifying a dangerous bacteria in a blood culture. There must be a procedure for immediate communication, usually by phone, directly to the clinician. Time is critical.
Can results be released automatically by computer systems?
Yes, the guidelines allow for automatic release through things like a Laboratory Information System, or LIS, but only if the lab has robust systems and controls in place to ensure accuracy and that competence exists.
Got it. And after the report is out, what happens to the sample? Storage and disposal?
Right. Samples are typically stored for a defined period, based on regulations and how stable the analyte is. Conditions matter: temperature, light. For histology, things like tissue blocks and slides often need to be retained for much longer periods, or there needs to be documentation if they're returned.
And disposal. Sounds like it needs careful handling.
Definitely. Segregation is key, using those color-coded bags for different types of waste. Sharps go into special puncture-proof containers, then it's handed over to authorized biomedical waste disposal agencies, following all the regulations. Chemical waste and electronic waste also have their own specific, strict disposal guidelines.
Okay, we followed the sample. Let's zoom back out to two really big themes that run through everything: safety and ethics. Protecting people, protecting principles.
Absolutely vital. Lab work inherently involves risks: chemical, biological, physical. So the guidelines mandate a comprehensive safety program, a safety manual, hazard mitigation plans, regular staff training.
What are some general safety measures?
Awareness is number one, knowing the hazards, tracking hazardous materials, having safety equipment like eye wash stations readily available. Using that universal biohazard symbol figure 1 in the dock shows it so everyone knows when there's a potential biological risk. Emergency drills, fire, spills, exposure incidents, and keeping detailed records of any accidents or incidents.
Why are those records so important?
Because you analyze them. You figure out why it happened and put measures in place to stop it happening again. Prevention.
And some strict rules for behavior in the lab.
Yes, absolutely zero tolerance for eating, drinking, smoking, or applying cosmetics in the work areas. Never use lab glassware for food or drink. Always wear appropriate PPE, lab coats, gloves, eye protection when needed. Handle sharps, needles, blades extremely carefully and dispose of them immediately in designated containers.
And chemicals.
Never pour chemicals down the drain unless specifically permitted. Most require hazardous waste disposal. Know the procedure for chemical splashes, usually flushing the affected area with water for a good 20 minutes. Labs also need a specific written chemical hygiene plan, or CHP, detailing how they protect workers from hazardous chemicals.
Basic hygiene and sanitation, too.
Foundational. Keeping the lab clean, restricting access, no unauthorized visitors, especially children. Mandatory hand washing. Using PPE correctly. Daily disinfection of workbenches and equipment, often with hypochlorite solution. Training housekeeping staff specifically on handling lab waste safely, and staff vaccination is strongly encouraged, especially for hepatitis B.
Electrical safety seems important, too.
It is. Preventing shocks and fires.
Ah.
Things like annual checks of electrical grounding, keeping access to electrical panels unobstructed, avoiding overloaded circuits or excessive use of extension cords.
Now, biosafety. That sounds like a big one. Dealing with potentially infectious materials.
Huge. It's based on risk assessment and the risk group classification of microorganisms. Group 1 are low risk. Group 4 are high risk, causing serious disease, easily transmitted. Most diagnostic labs need to operate at Biosafety Level 2, BSL-2, or sometimes higher, because they might encounter pathogens they weren't expecting.
So the level depends on the perceived risk.
Exactly. Risk assessment is the backbone. You look at the specific organisms you might handle, the procedures you're doing, do they generate aerosols, and that determines the required containment level, the safety equipment, the facility design. The guidelines detail the requirements for different BSLs, things like lab access, ventilation type, whether you need an autoclave inside the lab, use of biological safety cabinets, or BSCs. Table 3 in the doc summarizes this.
Okay, BSC's biological safety cabinets, why are they singled out?
Because many common lab procedures, pipetting, mixing, vortexing, opening sealed tubes, can create tiny, invisible airborne particles called aerosols or splashes.
Huh.
If the sample is infectious, these aerosols can be inhaled by the worker or cross-contaminate other samples or surfaces.
Things you can't even see posing a risk.
Exactly. BSCs are engineered enclosures that use airflow to contain these aerosols, protecting the person working, preventing contamination of the lab environment, and then sometimes protecting the sample itself from contamination.
Yeah.
They are primary defense against lab-acquired infections and cross-contamination.
Right, so a key piece of safety gear.
Definitely. Now, beyond physical safety, there's the whole ethical dimension. GCLP emphasizes that personnel must follow ethical principles, especially when dealing with human participants or their samples in research.
So it's not just rules, it's values. What are some key principles mentioned?
Well, voluntariness is core. People must consent freely, understand what they're consenting to, and be able to withdraw without penalty. Non-exploitation, ensuring fairness, especially for vulnerable groups. Social responsibility, considering the broader benefit and impact. Privacy and confidentiality, protecting personal information, is paramount.
But there can be exceptions to confidentiality.
Yes, the guidelines acknowledge necessary exceptions like mandatory reporting of certain infectious diseases for public health, or if required by law, like a court order. But the default is strict confidentiality.
Other principles.
Risk minimization, doing everything possible to reduce potential harm. Professional competence, only qualified people doing the work. Maximization of benefit, aiming for positive outcomes for participants or society. Having clear institutional arrangements for oversight. Transparency and accountability, like disclosing conflicts of interest, making findings public where appropriate, keeping records for audits.
Seems comprehensive.
There's also totality of responsibility, meaning everyone involved shares accountability, and environmental protection, responsible handling of waste and resources. These principles really form the ethical bedrock for lab practice, especially in research involving humans.
Okay, so we've got all these pieces: infrastructure, people, equipment, materials, the sample journey, safety protocols, ethical guidelines. How does it all come together to actually guarantee quality day in, day out?
That's where the quality management system, the QMS, comes in. It's the framework that integrates everything.
The document has a nice, simple definition of quality: doing the right things and doing those things right. And those watchwords: say what you do what you say, and prove it.
Exactly. It also clarifies the hierarchy. QC, QA, QMS. Quality control, QC, is the operational part, the hands-on checks. Is this specific test run accurate right now? It focuses on minimizing errors during the testing itself.
Like running control samples.
Precisely. Quality assurance, QA, is broader. It's about the processes you have in place across the entire workflow, from patient prep to reporting, that give you confidence the requirements will be met consistently. It aims to prevent errors at any stage.
And QMS is the umbrella over both.
Right. QMS is the total system, the organizational structure, the resources, the procedures, the policies, all working together to achieve quality and meet user needs.
Let's dig into QC a bit more. Internal quality control, IQC. That's the lab checking itself daily.
Yep. For quantitative tests, the ones giving numbers labs run control materials with known values alongside patient samples. They plot these results, often on Levy-Jennings charts, to visually track if the test is stable and performing within acceptable limits.
And there are rules for interpreting these charts, like statistical flags.
Yes, statistical QC rules are used. The guidelines mention common ones, like the Westgard rules. For example, a 1,3S rule violation means a control result is way off target, more than 3 standard deviations. A 10X rule means 10 consecutive controls have fallen on the same side of the average, suggesting a drift or bias. These rules signal that something might be wrong with the test system.
What happens if QC fails?
You stop testing patient samples with that method immediately. You investigate the cause, could be the reagent, the calibrator, the instrument, even the operator. You fix the problem, document everything, rerun the QC, and only resume patient testing once the QC passes.
What about tests that are just positive or negative? Qualitative ones.
For those, you use known positive and negative controls with each batch of tests, or maybe daily or weekly, depending on the test. Like for gram stains, QC is needed weekly or with each new batch of staining reagents.
Another QC step mentioned is reagent lot verification, checking new batches.
Yes, very important for consistency. Before switching to a new manufacturing lot of a reagent or kit, you compare its performance to the old lot using controls or patient samples. This ensures that a change in reagent batch doesn't suddenly shift results, which is critical for tests monitored over time like HbA1c or CBCs.
Okay, so that's internal checks. What about external checks? EQAPT?
External quality assessment or proficiency testing. This is crucial. It's where an independent external organization sends the same set of blind samples to many different labs.
Like a pop quiz for labs.
Sort of. Labs test these samples just like patient samples and send the results back. The EQA provider then analyzes everyone's results, compares them to the expected values, often determined by reference labs or consensus, and gives each lab a score or evaluation of their performance. The guidelines call this the best overall measure of a lab's accuracy.
What are the benefits?
It assesses your performance against your peers, identifies potential problems you might not see internally, provides objective evidence of quality for accreditation bodies, and can highlight areas needing improvement or training.
What's the process look like for the lab?
You enroll in a program, receive the PT samples periodically, test them within a time frame, submit your results, receive a report back comparing your results to others, and then you review your performance, investigate any poor results, and take corrective action.
What if there's no EQA program for a rare test?
Good point. If a formal EQA scheme isn't available, labs should try to participate in other forms of interlaboratory comparison, like exchanging samples with another reputable lab, or use other validated methods to assess accuracy. And labs should ideally choose EQA providers who are themselves accredited to a standard like ISO IDs 12043, ensures the grader is competent.
Internal audits are another quality tool mentioned.
Yes, these are planned, systematic reviews conducted by the lab itself, usually by trained staff who are independent of the area being audited. They check if the lab's actual practices match what's written in their SOPs and if they comply with GCLP standards.
What do they look at?
Everything. Documentation, sample tracking, equipment records, test procedures, personnel training and competence files, QC records, reporting. The works. It's about finding areas for improvement before they cause problems. Should be done regularly, at least annually. The doc even provides a model checklist in Annexure 7.
Risk management also comes up, preventing errors and harm.
Yeah, it's a proactive approach. Identifying potential failure points in any process, from sample collection to reporting, assessing the likelihood and potential impact of those failures, risk, probability, X severity, and then implementing changes to reduce or eliminate the risk, and documenting it all. Figure 2 shows a process map where you might apply this.
And finally, quality indicators, measuring performance.
Right, these are specific measurable metrics that help the lab monitor how well it's doing in different areas. Think of them like key performance indicators, or KPIs, for quality.
What makes a good indicator?
They should be measurable, achievable, actionable, meaning you can do something about it, balanced, covering different aspects, and tracked over time.
Can you give some examples?
Sure. Pre-examination examples could be the percentage of samples rejected due to labeling errors, or the rate of hemolyzed samples. Examination samples might be QC failure rates or instrument downtime. Post-examination could be turnaround time for critical results, or the number of corrected reports issued, or even patient complaints. Labs select indicators relevant to their services.
Okay, one last major area, data management. All that information generated needs careful handling.
Absolutely. From creating a sample record to archiving the final report, data integrity and confidentiality are critical. Integrity means the data must be complete, accurate, consistent, reliable throughout its entire life cycle.
How is that ensured? The guidelines mention LOCOA.
Yes, LOCOA is a helpful framework for data integrity. Data should be attributable, who recorded it, legible, can it be read, contemporaneous, recorded at the time it happened, original, is it the first recording or a true copy, and accurate. Following LOCOA principles, along with things like controlled documentation, access controls, training, and QA monitoring, helps ensure data trustworthiness.
And confidentiality, protecting privacy.
Paramount. Restricting access to patient data, preventing unauthorized changes or deletions, having defined roles and responsibilities, managing conflicts of interest. Data security involves layers protecting the hardware, up-to-date OS, antivirus, the network, firewalls, secure connections like SSL, the applications, strong passwords, maybe two-factor authentication, role-based access in the LISLMs, and the people. Security awareness training preventing unauthorized data removal.
What are ILIS and LIMS?
The IS is Laboratory Information System, often used in clinical labs for managing patient samples, tests, and results. LIMS is Laboratory Information Management System, often used in research or batch testing environments. HIS is Hospital Information System, which integrates lab data with the broader hospital record. These systems are crucial for tracking and managing data electronically.
And procedures for securing data.
Yes, documented procedures for data protection, security measures, backup, and how any edits or deletions are handled crucially, ensuring there's an audit trail showing who changed what, when, and why.
Something easily forgotten. What about disasters?
A disaster recovery plan is essential. How will the lab protect its data and maintain essential services if there's a fire, flood, major power outage, or other catastrophe? Needs to be planned and tested.
And finally, how long are records kept?
Labs need to store records physical or electronic securely for periods defined by national or local regulations.
Phew. Okay, that was definitely a deep dive. So much detail.
It really highlights the sheer complexity, doesn't it? But pulling it all back together, what the ICMR GCLP 2021 guidelines describe is this incredibly comprehensive, interconnected system. It touches, well, literally every part of how a lab operates.
From the building itself, the training for every single person?
To the exact steps for handling a tiny sample, the rigor of the tests, the non-negotiable safety rules, the ethical grounding, and the secure handling of every piece of data.
And the core purpose seems crystal clear. It's all about ensuring those lab results are reliable and have integrity. Without that, you really can't have quality healthcare or credible research. It's foundational.
Yeah, absolutely. Hopefully walking through this gives you, our listener, maybe a new appreciation for the layers of precision, the careful practices, the whole system, really, that stands behind the lab information you encounter.
Right.
Whether it's your own results or news about a medical study, it's all designed to build and maintain trust.
It really is an incredible amount of detail and effort, isn't it? Every rule, every check designed to minimize error, maximize accuracy. But, beyond the science and the systems, it makes you think about the human element, too. The actual people, the lab professionals, trained in all this, committed every day to these standards. What does that dedication, that commitment to quality really mean for the impact that testing and research have on all of us, on society as a whole? Makes you think.